Okay, so welcome back from the little comfort break. We're going to move on now to just the final part of the session. But obviously, you know, if things are starting to get a bit tiring for you, please, if you do want to leave a little bit early, when you go out, just leave your lanyards with your name badges on the desk just outside where you collected them, because we appreciate it is a long day for some of you. So this has been our first hybrid conference. So please see on the table, you should each have a feedback form. Please give us your feedback. It helps us to improve things for next year. Just what has worked, what hasn't worked. It's really important for us to get that feedback, what you enjoyed most about the day. And then if you can leave those completed forms with Alan at the back, that would be absolutely fantastic. And for those of you that are watching online, the link will be shared with you in the chat, and we will also email it to you after the conference as well. So I'm going to welcome back John. Is Jean with you? Oh, okay. So I'm going to welcome back John, who will talk through the feedback that has been provided.
Cool. Hopefully I've got some slides ready. Okay, so thank you for all those people that did provide some comments. We've had quite a few online. Thank you very much. And what I've tried to do is just kind of group them into themes that people are kind of talking about the centres themselves specifically. I think before I start going into some little bit of detail, I think one of the things that came out really strongly is once a patient gets in front of a BEHÇET'S specialist, whether that's a specialist nurse or a consultant or a support worker, the care that they get is second to none. The issue seems to be getting into that specialist service effectively. Some of the things that people are talking about, there's some, as I mentioned in my little story about Oldham Athletic, my team and the chairman, Frank, some of the things that we could do quickly, I think, some quick wins, you know, the ladies' toilet not flushing the football stadium, you know, things like, can we find the clinic? So if you're going to a clinic as a first-time patient, do you know where it is? Is it obvious where to go when you get to these vast hospital complexes? Do we know? Do we take that stress away from that kind of first contact? And I think there's work that we can do there just to improve that kind of flow through a hospital environment for you. We do have to share resources with the NHS. We are a rare disease, and I guess we can't always insist on having our own dedicated facilities on a hospital site. But I think what's coming out from some of the comments is when we come to clinics as patients, most of the time we're not feeling very well. We've gone to the centre for a reason. And it would just be nice in some situations to be acknowledged by the reception staff that may come from different departments, that we do have this flaring disease. And you just need to just check in to make sure we're okay when we're sat there for whatever length of time it takes to go through a particular appointment. There are obvious ways we can hopefully look at making improvements to communication. That came out quite large in the feedback session we just had. Just making sure that information is flowing between the centres, between the consultants, the patient, the GP, so anyone can understand where you are in your particular BEHÇET'S journey. And that information is accessible to the people that need to see it when they need to see it. That seems to be quite important. And when you're not in a centre, when you're not in a clinic environment, is that kind of out-of-clinic support. Can we get in touch with a clinic when we need information? Do we know where to be referred to if we've got a particular problem? So I think there are some bigger communication issues we need to kind of get our heads around as a team and try to make improvements there for us. Waiting times came up, obviously. We had experience of the NHS at the weekend, 7 hours in A&E. Is that acceptable? We seem to got ourselves in a position where it seems to be. But we seem to compound the problem by there's a waiting time to see a consultant, there's waiting time to go and have your bloods done, there's waiting time to go and have your prescriptions picked up, and we just wonder whether there's anything we can kind of do to kind of assist that flow of information again, to just take out some of the stress of being in the hospital environment. BEHÇET'S obviously is a complex illness, And again, coming back to that information and sharing the information with other consultants, not necessarily in the BEHCET'S centre, is really key. So that if you need to go through any other kind of surgical procedure, people know that you've got BEHCET'S and what treatment you're on, and they can just tailor whatever treatment you need surgically or whatever, that's not going to have another impact on your BEHCET'S. Thinking things like, time to heal, things like that. Just make sure that information is out there, that people can access it in a timely fashion. The processes seem to be an area that we need to look at improving. So the kind of flow from making an initial appointment to being told you've got an appointment, to being told you've got a cancelled appointment or a postponed appointment, there seems to be some communication issues where we're not always aware that appointments have been made in the first place. I think a lot of appointments these days are made centrally, not within the BEHCET'S centre itself. And sometimes a falling down of communication between the central area and the patients themselves. And again, when appointments get cancelled, which they sometimes have to be for whatever reason, again, that information doesn't seem to be flowing back to the patient. So you may pitch up for an appointment and not being expected there, which again just adds further stress to the situation. But generally, that kind of process of information flowing through the system seems to be an area that we can look to improve upon. Do we know where prescriptions are in the system? Do we know the right drugs are being prescribed? Do we know the right dosage is being prescribed? So the kind of entire flow of information is something that we maybe need to get our heads around and try and improve. Again, just contacting the clinic in the first instance. I think obviously there's been lots of issues with Brexit and COVID and now the cost of living crisis, etc. We seem to have lost the face of the NHS. Everything seems to be done either through email or through the telephone, and then you get an email back. We seem to have lost that face-to-face contact with our clinicians. And there's lots of reasons for that, but I think, from what I've seen from the feedback today, that face-to-face is so important. You need to be seen to show that you are in a flare. And I think, as Steve said, that you can lift that mask and actually see the real BEHCET'S patient behind that. So I think, hopefully, as we come out of the pandemics and other issues, that the kind of face-to-face contact time will start to increase. So those were the kind of main themes I was picking up on in the emails that we received and the conversation we've had. What we'd like to do now is kind of take away these, just think about them as Team BEHCET'S, BEHCET'S UK, the NHS, and just see what we can do, some short wins, quick wins, what we might need to start thinking about as more medium and long-term goals. But I think the important thing for us is we want to be here to be listening to what you've got concerns about. There are ways in which you can obviously share your frustrations, and we don't want to stop those conversations, but if you want us to see and make improvements, we need to be told about what's going on, whether it's good or bad, and we can then do something about it. We raised in a meeting yesterday the role of PALS within the NHS, and I think it's an English-only system, is it? Again, we need to think about how we use PALS within the NHS. From what I understand is, without information and data, they don't move. So using a service like PALS, if things are not progressing as you want them to, gets the data in the system and it has no impact on your ongoing care. It's investigated by an independent team within the NHS. And at least then they can start to see and get the data as to what's going on out in clinics. So please, feedback to us. We want to listen to what you've got to say. We want to hear your stories. We want to share your stories with the NHS and with BEHCET'S UK through newsletters, websites. We want to share that, and between us, hopefully start to make your journey through your clinics, etc., a little bit more bearable for you. But I can't promise, in the words of my chairman at Oldham Athletic, I can't promise you Lionel Messi, but we'll do what we can. Thank you.
Thank you, John. We are now going to move on to Dr. Sarah Sacoor.
Hi everyone, hope you're all doing okay. It's the last talk before the Q&A. So I was going to talk to you about practical tips for medication. It's quite a nice follow-on from the last talk about some of the issues that people have in terms of arranging their medication, the logistics and things. So first of all, some of you may or may not have seen this. It's on the BEHÇET'S website, and it's the treatment pathway. It looks very, very complicated, but I will just break it down. So the far end of the triangle is for less complex disease. So things like the mouth ulcers, the skin problems. We start with the lower down medications, so topical things, mouthwashes, and then we move on to medication, so tablets like azathioprine, mycophenolate, and then for more severe disease or sight-threatening disease, organ-threatening disease, we have our biologics. So why is medication compliance important? It's there to manage your symptoms of your BEHÇET'S disease. It helps to prevent severe complications, so loss of vision, clots, neurological complications. It's not good to stop something suddenly. If you stop steroids, you can have a steroid crisis. And it's really important that if you're worried about your medication or you think that you want to stop taking it, that you do seek advice first. So why do patients take their medication? So most patients are quite good. They understand why they need the medication. It's been prescribed by their healthcare professional, and hopefully they trust us that we're making good decisions for them. With them. Most people are aware that if they stop their medications, that symptoms can start again. People are worried about severe disease. They're worried about losing their eyesight, about ulcers coming back. And some patients have medicine compliance aids, so they take what's in a box and they're quite good at taking it every day. There are lots of reasons why patients stop their medication. And it's really helpful for us to understand why people have stopped so that we can try and support them. Some people get side effects and they are worried about them. Sometimes we accept a degree of side effects. So for example, if you're going to lose your vision but you've got a bit of tummy upset, we might accept that as an acceptable side effect. But if you are having severe problems, do talk to us. Some people forget for various reasons, the stresses of life, looking after the children, they've gone to work. People run out. It's really important to try not to run out, and that does take a bit of organisation from our part, but also from your part in terms of letting your doctors know when you're running out, getting your blood tests organised. Some people feel better, and then they think they don't need it anymore, and then they stop. The problem is that those medications have been controlling the disease, and sometimes if you stop the medication, those symptoms will come back. Some people end up with an infection. For example, if they've gone to hospital, someone might stop their medication. Just let us know, or get those doctors to contact your local, your BEHÇET'S doctors. Particularly since 2020, people have been really worried about COVID and immunosuppression. At the London Centre, we advise people not to stop their DMARD, so the tablets that they take, colchicine, azathioprine, and actually people who stopped their medication had slightly worse COVID outcomes. So it's, from our point of view, it's better to continue, but please do ask your doctors for advice. People are not sure how long to take it for. Sometimes that might be miscommunication on our part or misunderstanding. We write you a prescription and it's for 3 months. You take it away, have 3 months, and then forget to renew it or not sure what to do. And pregnancy as well, which we'll come on to. So there are different studies that have looked into reasons for people not complying with medication. It's a hidden risk factor associated with oral ulcer activity in female patients. Another paper shows that it's more common in males, people with low income, and people who don't have good education about their disease, employment, and treatment with NSAIDs. So that's things like ibuprofen. It can be affected by the support system and the nature of the treatment plan. So perhaps that's for us to give you clear treatment plans and make sure that we explain things properly and offer you the right support. and adherence increases with age. So I'm going to just run through some of the common drugs that we use that are on that BEHÇET'S treatment pathway, just for some practical tips. Not every medication will apply to everyone, so please bear with me. So biologic drugs, they're the infusions and injections. They're usually saved for people with severe disease, so uveitis, clots, neurological disease, or where other medication hasn't been effective. It's not usually a long-term treatment. It's tailored to individual patients, but usually is given for 6 months to a year, sometimes longer if needed. A lot of patients are not aware that they do need to continue their other medication alongside. So if you're taking something like azathioprine, mercaptopurine, mycophenolate, it works together with the biologic, and it also helps to stop developing antibodies to the biologic. So that's really important. If you are having your biologics in another place to where you normally see your BEHÇET'S doctor or another doctor who's giving you your biologics, hospitals don't see each other's blood results. And a lot of people don't know this. In hospital, we can't see the blood tests you've had with your doctor. So it's really important that you collect blood tests that might be useful to another doctor. Just ask, most people will be happy to give those to you. The other thing is, if you're having blood tests with your doctor, if you have got access to your NHS app, you can get your blood tests there. But if you're having trouble with that, you can just ask your GP to give it to you. Smoking can affect how effective biologics are, so we would advise not to smoke. Pregnancy, there is limited evidence on the safety. However, if there's a clinical need, then we will continue. Steroids, so many of you will have taken prednisolone at some point. It has various side effects, so we tend to only use it as a rescue drug. It's not a long-term medication, but it's very, very useful when somebody is having an acute episode and needs to damp down the disease. Hopefully the doctors will have given you a plan about starting and stopping and reducing doses, but it's really important to follow that and not to try and stop it yourself or reduce it or increase it yourself because of the side effects and the danger of stopping it abruptly. Colchicine. So, sorry, I've gone to the highest level drug. We're going back to the bottom. So colchicine is one of the first line drugs. It's an anti-inflammatory, it's extremely effective, and it's been used in BEHÇET'S for over 50 years. So before 50 years, it was used as an antibiotic for leprosy, and then it was found that it had really good anti-inflammatory effects, works on the neutrophils, so it works really well in BEHÇET'S disease. So we know that people have had concerns on various forums that colchicine is not safe, but we know it to be safe. We use it in quite small doses in BEHÇET'S disease. It is also a treatment for other conditions like gout, which they use much higher doses for, but at the doses we use, it's safe. At higher doses, it can cause tummy upset, but at the smaller doses, it tends to not be too bad. It is safe in pregnancy and safe in breastfeeding. At the London Centre, we tend not to give it in pregnancy because of the risk of morning sickness. So we have to be aware of the pregnant patient as well. So DMARD stands for disease-modifying anti-rheumatic drug. Don't worry about that, but it's just the other tablets that work on the immune system. So these take several weeks to take effect. It's not like you'll start the tablet and a few days later you'll feel better. You need to give it weeks, even months, to start to feel better. Azathioprine is one of the first-line drugs. We check a blood test called the TPMT to make sure that you can metabolize the drug and have it safely. If you can't, then we may give 6-mercaptopurine, which is the same drug family, but you don't need such high levels of that enzyme. You will need regular blood tests to take it. As I said, make sure that you get the blood tests arranged or speak to your hospital, find out what the logistics are, and just make sure you're a bit organised with that. and it's safe in pregnancy and breastfeeding. When you first start taking it, you feel a bit unwell for a few weeks, you might have some stomach upset, but that should settle down. If you have severe side effects, then talk to whoever prescribed it to you. Mycophenolate is another alternative drug. Again, you need regular blood tests, but you cannot have that during pregnancy, so both men and women shouldn't conceive whilst taking mycophenolate. And then there's cyclosporin, which is another DMARD. So alongside blood monitoring, you need to just be careful of the blood pressure. So logistics of prescriptions, it will differ between centres and between hospitals. Sometimes GPs won't prescribe DMARDs, so do discuss with your doctors how it works. At the London Centre, we're happy to do prescriptions for you. We take responsibility, but you do need to let us know in advance. So give us 3 weeks or so that we can get the prescriptions done, post it out, account for any delays in post or any admin delays, and we need the blood test results as well. And we've already talked about the NHS app. Benzaderm, so this is a topical treatment. We use it at the London Centre, and hopefully it will be coming to the other centres as well. And it's a gel that's used for genital ulceration. It's quite simple to use. You can use it 3 or 4 times a day. It helps with the pain, and it's also a bit anti-inflammatory. How to use it. So for women, we tell everybody with any ointment or gel that's going in the genital area, always front to back, clean hands, and hopefully we'll have some more information coming soon on the BEHÇET'S NHS website. Then we've got triorosol mouthwash. So this was previously known as triple mouthwash. It's extremely effective for the oral ulcers caused by BEHÇET'S, and it helps with the scarring as well. Again, we'll be having videos and information put on the website, but for now I can show you a video which explains how to use it. I'm Sacoor. I'm a specialty doctor in oral medicine and BEHÇET'S disease, and I'm going to be talking to you about triorosol mouthwash. Triorosol mouthwash has been developed for patients to use for conditions which affect their oral mucosa. For example, this could be oral ulcers caused by systemic conditions such as BEHÇET'S disease or Crohn's disease, but it can also be used in conditions such as lichen planus, vesicular bullous disease, graft versus host disease, and patients with chemotherapy mucositis. Triorosol mouthwash contains ingredients which are effective at healing oral ulcers and other lesions, and is very effective when used correctly. It comes in a box of 120 sachets, so for a patient using this 4 times daily, this should last a month. I'm now going to show you how to use the mouthwash. So it comes in a sachet of powder, and there should also be a cup in the box. You should measure out 10 millilitres of warm water in the cup, open the packet, and drop the powder into the cup. You should then leave this to sit for a few minutes to allow it to fully dissolve. After a few minutes, you can have a look to see that the powder has all dissolved, and then it's ready to use. You should then use the mouthwash for 2 minutes. You may wish to set a timer to make sure that you are rinsing for a full 2 minutes. You should make sure that you're getting all sides of your mouth, so side to the cheeks, lean forwards to get the lips, and you may also need to gargle, particularly if you've had ulcers in your throat. After using the mouthwash for 2 minutes, it's important that you spit all of it out. It should not be swallowed. You then shouldn't eat or drink or rinse your mouth with anything else for 1 hour after to allow the mouthwash to take effect. Some patients experience a black coating on their tongue or their teeth, but this is nothing to worry about and can be cleaned off by the dentist or hygienist. Patients are usually advised to use the mouthwash up to 4 times a day, but should follow the instructions given to them by their doctor, dentist, or other healthcare professional. If you are a patient with BEHÇET'S disease and require a repeat supply, please contact us by email at bhnt.londonbehçetcentre@nhs.net. If you are a patient with oral medicine, you can contact dentalmedicine@nhs.net. If you are a doctor, dentist, or healthcare professional and you'd like more information about the mouthwash or how to order a supply, please also contact us by email. Thank you for watching. So that video will hopefully be available online, so you can refer to it. If you're having problems, if you're using Triaerosol mouthwash and having problems, it's not dissolving or you're getting residue in your mouth, just send us an email and we can do a bit of troubleshooting on that. And if you're from another centre, hopefully it'll be coming soon. I just wanted to briefly touch on some other topical treatments. So Difflam mouthwash, big green bottle, it's good at helping with pain for ulcers. So with the Triaerosol mouthwash, you shouldn't eat or drink afterwards. So it's better to use it after meals. So for example, after breakfast, after lunch, after dinner, before you go to bed. But Difflam is good to use before eating, before brushing your teeth, just to help with the symptoms so that you can eat properly and brush your teeth properly. Lidocaine and xylocaine, anything that's a numbing gel or spray, it's okay to use in very, very small amounts. However, if you've got BEHÇET'S and you're getting lots of ulcers, using it frequently is not such a good idea because it can have neurological and cardiac effects on the heart as well. And then you may also have steroid ointments that you use for genital ulcers and other lesions, and you should just follow the instructions of your doctor. So in summary, it's important to comply with medication. People have different reasons for not complying, and we hope to be able to support you if you're not able to take your medication or thinking of not taking it for some reason. But please do speak to us. Try and organise blood tests on time. Let us know if you're having problems with getting prescriptions or running out of medication. And the healthcare team should be there to support you all. Thank you to everyone at the London BEHÇET'S Centre, and thank you all for listening.
Amazing, thank you. Okay, so we're going to move on to the medical Q&A now. So if you've submitted a question, it may well be one of the ones picked to be answered. So could I call the medics to the front?
Besides Prof. Jarwood, this is our team, right? And I have to say thank you for listening today, but also thank you for, where's Jean? And Jean's missing. Come on, Jean. And no, Azimun, why aren't you here? Azimun is the best person to take your blood. She calms you down. She explains the things that I haven't done so well. Okay, so absolutely essential. Okay, so this is us, and we're responsible for running 4 sessions a week. And Thursday and Friday are very long days. And I have to apologize. Sometimes patients have to wait. If I have a patient that's been going for 20, 30 years, hugely distressed, I'm the one that has to sort them out. And sometimes it can take 3 hours to do that. And for that, I apologize. And then there's another concern which has come through the questions of our centre closing. No, can I reassure you, we're just moving, right? And we're waiting for the signage. We're going to a bigger centre upstairs. What has happened over COVID, there's been reconfiguration of the hospital. We were the largest receiving centre. So during COVID, we had 250 patients in ITU, and we had 850 patients who were oxygen dependent in the hospital. So we all squeezed up. We can't manage in this small space, and we're waiting for our signage to be done, so it'll be there. And Bridie will be there. So Bridie is the person who receives the patient, and when she's there, nobody complains, right? Because they go to Bridie and she sorts you out. At the moment, we're using ENT reception, which is a huge problem for the patients. So for all of that, I take personal responsibility, and I really apologize. And these people are the people who make things happen in a clinic, and not me. And Nardus is both, so we've got two nurses. Nardus is both the nurse and the nurse manager, and Azimun is both the sister and the nurse who does all the, she's half research and half on the, so half on the academic side and half on the NHS side. So that's one question, and I hope that's answered. And then, hang on, here's a whole load of questions. And I'll very quickly go through things about, I've had 4 COVID jabs, last on Tuesday, but never stopped taking my pred. How will this affect my immunity? So we actually are continuing to monitor people for the effect of medication on their vaccination. If you're in our centre, then there isn't any problem. I have to work out a logistic way if you're at another centre where we can have the ability for you to check. You might find that your centre has the ability to check your antibodies, because it's a NHS test actually that should be available. Right, so that's one of them. Chances are, if you were on a low dose of steroids, wouldn't have made any problem. If the steroid was in conjunction with another DMARD, then you might have a bit more of a problem, especially mycophenolate. The levels are quite low. But every time you have another one, you increase your antibody response, which you would have seen on the slide that I showed, right? And remember, everyone is now waning, so you're doing this, okay? So you need this booster now. And from the data we have, the uptake on the booster is low, okay? So it's normal. The first vaccine, the uptake was over 70%. We're sitting on 20% of people who are BEHÇET'S who are not going for their jab. Okay, so if I can ask you, and when you have it, the other thing is, can I have that and the flu jab at the same time? There isn't any reason why you can't. From my point of view, because I think you're hyperinflammatory, you're going to have a response to the jab, and 2 of them, you'll have a very sore arm and be ill. And if you haven't had a problem last time, it should be okay. But, you know, you can take it a week or so apart. All right. So that was one. And then Sarah's explained about the Traurosol. I know that the other 2 centres have now asked for the Traurosol, and the company who formulates it are working with them. But we will have all the details on the website. So I'll give this one to... So the question is, the evidence that cold water therapy is effective.
Cold water therapy?
Yeah.
There you are, see?
Okay, all right. I know a little bit about people using cold water therapy in cancers. And I think the idea is to slow down progression of the disease. However, when patients are really immunosuppressed, you know, the chances are that you're going to get a cold when you come out of having the cold water therapy. And I know someone outside of work who had their daughter have cold water therapy. It wasn't very effective, right? But that's all I know.
I think from a psychological point of view, there was there was something about if you had a cold shower and things like that.
Yes.
Help with your mental health.
Yes, well, cold water shower is different. It's different from cold water therapy. If somebody wants to say, Gemma?
Oh, so I was just saying that there was something that I watched recently about cold. I didn't ask this question.
Yeah.
But that if you exposed yourself to a cold shower every day, that it would actually have a positive impact on your mental health. But it's not something that I am willing to do.
Yeah. Cold showers are very good. I have a cold shower. It's very good for you.
You're not convincing me.
A positive outcome there. So I'm going to ask here. And we asked about colchicine, if it's safe. I think Sarah answered that question. I just don't give it to women in pregnancy, all right? You start vomiting like mad. You vomit enough, you feel awful enough. I'm a woman. I wouldn't. And I once, this is a learning experience, I gave it to a patient and she had hyperemesis and nobody knew why she had hyperemesis. And we kept on saying, it's safe, it's safe. And when she stopped it, I don't think she'd ever forgive me. So I don't want anyone else to curse me. Okay, so we don't use it, but it is safe in pregnancy. The best drug, if you want to have babies and you're on a DMARD, is azathioprine. It's good pre-conception, conception, during having your pregnancy, and afterwards. You can breastfeed on it again. Mycophenolate, if you're a man, just watch your sperm count. All right, I think in the doses that are given at some centers, okay. If you're still wanting to have children, ask them to send you for a sperm count. Certainly if you ask us, we will send you to have that. But it does have a detrimental effect on men's sperm. Okay, so I think I gave Desmond some questions. Yeah. Sorry, Dr. Kidd. Okay, that's yours. And there was one for you as well, yeah. Do you want to do yours first? Yeah. Okay. So, Mr. Gabra will do his first.
The question is, this patient suffered from dilated pupil and her doctor told her the pupil would be large and would not come back to normal size. Here there's two issues. If the patient is suffering from a cosmetic appearance of large pupil or suffer from the photophobia, the effect of the light that dazzles them at night or during the daytime. When you have anterior uveitis, the aqueous inside the eye becomes sticky, and consequently, one of my slides showed that there is adhesion between the iris and the lens. And if her doctor gives us some dilating drop during the inflammation, the pupil get bigger and stick at the periphery of the lens, and then the pupil will be hard to return back to normal. So if the appearance is not good, then a contact lens can solve the problem. And if she has photophobia or sensitivity of light, also contact lens can solve the problem. The alternate is a surgical procedure. We dissect it and bring it to normal size. But once the patient have uveitis, when you do surgical procedure, we trigger insult to the eye, and that might activate the disease once more. So the safest way of dealing with that would be a colored or pinhole bandage contact lens. Sorry, yeah, the pupil could not return back to normal.
Okay, thank you very much. Dr. Kidd, I think there's 3 on the list.
There's 3 on the list, all the same, and then on the second page there's a reference to enteric neuropathy. Okay. So I'm going to assume that this the same answer will cover all 4. The autonomic nervous system is the part of the nervous system which controls automatic functions, so the heart, breathing, how the gut works, urinary function, this kind of thing. And we have, over the last few years, identified thankfully a small number of patients who have a specific and repeating set of symptoms which involve the control of the muscles in the gut. There's a thing called gastroparesis, which means that the stomach stops working, the stomach fills and doesn't empty, and then there's repeated vomiting, which can obviously be very hazardous. Weight loss occurs, malnutrition occurs as well. And there's a condition called chronic intestinal pseudoobstruction, which is allied to that, which is the same part of the nervous system which allows the small and large bowel to work as well. I'm sure you know that the bowel is basically just a rather fancy, rather complicated tube with from one end to the other, and it requires the nervous system to allow it to work correctly and in a timely way. So this condition is recognized as a consequence of a variety of different things that can happen with degenerative neurological diseases like Parkinson's, for example, and inherited diseases as well. And then in the rheumatic world, it can occur in muscular conditions like scleroderma. There are some inflammatory conditions which can cause it as well. It occurs in lupus, for example, and it can occur in what's called a paraneoplastic disorder, which is an inflammation which occurs in the nervous system associated with cancers. And it turns out that this condition in Behçet's syndrome is very similar to those. And so we sat back and said, well, how do we treat these conditions outside of Behçet's syndrome, and would that form of treatment be helpful to those who've got it with Behçet's syndrome? And it turns out that that it is. There's a treatment called plasma exchange, which is extremely complicated, very difficult for the patients to withstand themselves, but which does seem to provoke considerable benefits. It's very uncommon. We investigated early on if the symptoms develop, because we find that if we escalate the treatment for the systemic disease, the symptoms often regress and settle. And these patients that I've described to you are more people in whom it hasn't been recognized and it's been there, allowing it to get more and more severe for a long, long time. So we're confident that the treatment is helpful. It certainly is helpful, but we've also found out from the point of view of the pandemic and these treatments being stopped in various hospitals that the treatment is supportive rather than curative. So the condition tends to return whenever plasma exchange is stopped. But happily, whenever plasma exchange is reinstated, the treatment continues to be beneficial.
Okay. And then just plasma exchange is not on our treatment pathway. So currently we have no funding for it, although a lot of patients found it very beneficial, and we got some documented evidence showing how antibodies fall with pheresis, especially anti-neurologic antibodies. I'm just giving this to, you've got your question, yeah?
Just one more thing about the plasma exchange. It's just really kind of clinical impression. So patients do improve symptoms, but they report no change in any cognitive symptoms. They still seem to have, they seem to kind of persist despite improvements in other symptoms.
Yes. And we're just starting to do a bit of research on that, because there's someone in neurophysiology to look at all those samples of patients who have had plasmapheresis and see if there's any a protein leaching out with the pheresis, or if there's anything that accumulates that we're not taking out. Okay, Bindi, don't you have a question, Steve? What did you do with your... There was a question for Steve. I don't know what he's done with it. I'm sorry. I'm sorry. Bindi, do you want to just look at this? Somebody asked me about Behçet's being labelled a disability under the Equality Act. And I think there's like 4 questions around it. It is, all right? You don't have to ask. It doesn't have to go on the list. It is, right? I do know something about the Equality Act because I used to teach, you know, all these things, and it is a disability. So you don't have to prove it to anyone. Remember, if you have a disability, there's due adjustment, but it's made by the organisation and not you, right? So that's a very important, and I hope it answered whoever asked the question, because there's several versions of it in the thing. So, Bindi, do you want to just take the question?
The question is, how long does it take for someone to become dependent on steroids to control the disease? How long is a safe period of use? It's a really difficult question because I don't think there's a very clear answer. Taking steroids obviously taking steroids long term does have significant side effects. But if it's controlling your disease, we have to look at the overall picture. Each patient needs to be assessed individually. I don't think we could ever make a blanket decision on this is a safe period, you can only take them for this much, this is the dose, and this will work for everyone, because it just doesn't work like that. Every patient would need to be assessed individually. If steroids are being used short term, they can help to control the flares, but some patients do end up on long-term steroids. We try to use the minimum dose that we possibly can to minimize the side effects of using the long-term steroids, but to help to control their symptoms. We try to avoid using steroids if possible, or to use them topically as possible, and use other therapies instead of them. So I'm sorry, that's not a proper answer, but it's the best I can do.
No, absolutely right. And Mr. Garbo will say to you, do you want to add to that?
Sorry, I was reading the question.
Okay, no, I'll tell you what he would add to it.
Sorry, regarding steroids.
No, that occasionally you have to use topical steroids for the eyes, yeah?
Yes.
And
It's mainly for the anterior segment. When you have acute anterior uveitis, we have to use a steroid topical treatment, and that will suppress the inflammation. And the good thing about the anterior part of the eye, when we examine the patient on slit lamp, it reflects the effectiveness of the treatment. So you can see a reduction in the number of the cells and the flares in the anterior segment, and then you can modify the steroid use. And you have to monitor it in relation to the pressure in the eye, because steroid can raise the pressure in the eye. So yeah, it is important that we use topical steroid.
okay.
There's one more question, or shall I?
No, you can. That's okay. That's periodontal. Well, just one for Sarah very quickly, and then I would ask Nadas, who is our Führer. All right, she's in charge. She's in charge, and we all do what she says. And I just wanted her just to explain about the flow of the clinic, because I think it can look quite archaic to people, but when you have several consultants all seeing a patient, and then Azzy has to take their bloods, and and they all have to be weighed and have their obs done, the clinic can be actually quite difficult. And I know sometimes people think they come out of seeing a clinician and they should walk straight into Azimun, and Azimun already got 2 people from another clinician waiting to see her. So, person in charge, can you just tell everyone what we do?
Okay, so obviously I can only speak for the London Centre. I think all centres run their clinics a different way. In terms of the London Centre, it could look very chaotic, because there may be a day where the patient, mostly the review patients, will come and see maybe 1 or 2 clinicians and leave. Another day where it can be a very long day. And if we do have a lot of new patients, I suppose if you can look back when you are a new patient, you are given all the time you need. And from the history that you've been to several doctors and you come into the centre to have your diagnosis over confirmed or being told whether you have BEHÇET'S or not. Again, it can take a long time, and it can be very tiring. And sometimes I think we pull the patient one way or another without them, kind of not knowing what's going on, and it can feel very daunting. But we kind of try to accommodate, everyone need, and try to minimize the amount of time they're waiting, but it's not always possible. So when the patient come in, we pull them to see, usually the eye doctor would be the first call of place. And then after that, there's gaps in between, and see the clinician that they need. I think sometimes there's a misunderstanding, because it's an MDT clinic, they will see every single specialist. But it could be that after a while, they will only need to see, one specialty, depending on what their manifestation of their disease is. But normally for the new patient, we try to get them through everyone, so that we make sure that they get the first of their consultation out of the way, and then we try to make the review appointments later and kind of more tailored for them. But I think it doesn't work all the time, and we just kind of need a communication from patients more.
I'd like to make a small comment. Yeah. Okay. Simply because when I see a patient, all patients need to be dilated so the pupil get larger. First, we check the vision, the color sensation, the slit lamp examination. Then we have put drops in their eyes, and they have to go out and wait for 20 minutes. So there is a good management from Nardos and Azimuth that the patient can see another doctor while the pupil get dilated, because they have to come back again to see me. So the patient doesn't wait in the waiting area doing nothing. So we really get advantage of moving the patient, and we classify follow-up and the new patient as well.
Yeah.
So
Sometimes it seems unfair because the patient's just gone in, come out, gone in. But I think when we move into our new area, it will be much better because Bride is good at doing that. Azimuth, do you just want to do it? So the patients have their blood taken in centre, and Azimuth does that. Azimuth's also in control of all the research, so she has to make sure that everyone's consented, that the only way we can run and give you this data is actually having really good data about you. And we can do the research because you've given us permission to do that. And that is a huge responsibility, and it's Azimuth. So she runs all of that. And she also, do you want to talk about the databases and things that you run? So she's a nurse, she's also a techie, right? So, so did that as a primary degree.
I'm not that sure. Normally after your session, however long you've been with us on that day, I would gather the data if you've consented to research, so we can use the information you've given to us, see how you're doing, or if you've come in with a flare, we can see what went wrong and maybe find another way to help you by your treatment, or maybe later on with actual medications, or sorry. So we've created a database where we can put that information in at the end of the session. And the only way we can do that is if you give us as much information as you can. So like I said, with your medications, how you're doing, how you have been before you've seen us, and if there's anything that goes wrong after you've seen us, if you let us know as well, so we can keep things up to date. That helps a lot. We then pass on to our research team, who then takes that data.
And sometimes, people don't comply. And then they come and see me and they're a bit scared to say, I didn't take my medication. So there's a safety valve for patients where there are things they wanted to say and they felt a bit intimidated. Azimuth holds that safety valve where people can go and have a bit of a chat about it. And she also makes sure that the bloods are taken, unless we have a real problem, they're taken in-house, and she's responsible for doing that. Do you want to answer your question?
Can I make one point about the clinic flow? I just wanted to add to the clinic flow issue and the fact that patients feel that they're waiting for quite a while. Another point following on from Nardos is that it might be that on one day lots of people need Prof Fortune and don't need Dr Kidd, in which case there will be a longer waiting time, and it's not always something that we can plan, it's just what patients present with on the day. And it might feel that you're waiting for ages, but once you're in with myself or Dr Gokani or Professor Fortune, you have as much time as you need. If you need 2 hours, that's fine, you're given the time that you need once you're in there.
And that was the point, that in COVID we stayed open all the time, right? And so sometimes, on one occasion, someone drove all the way from Cornwall. We didn't have space in the clinic, and he said, I won't go, and I'll wait. So I only started seeing him at 8 o'clock at the evening, but he felt that he came and he got seen. And I think COVID was a really difficult time for patients. They weren't being able to see doctors. They weren't being able to access a whole load of things. And it's now also a problem. We're not the general practitioner. So when you go to your BEHÇET'S centre, they don't deal with your comorbid disease. but sometimes patients are so distressed by all of that, it has effect on the BEHÇET'S. So it's important for us to be able to disentangle that and to give the patient, and if the patient needs, a member of staff will ring the GP or the surgery and facilitate an appointment. And all of that takes time. And as I say, this is us, you know, and we do 4 sessions plus all the telephone. So there's a whole day that there are 3 people, just a whole day on the telephone with patients' needs, all right? So having a telephone consultation. And then I'm going to go back. Someone asked about anakinra, the IL-1. Do you want to ask something? Oh, go ahead. No, you go ahead.
So someone asked, can you get gum pain and inflammation with BEHÇET'S? If so, does it respond to colchicine? So gum pain and inflammation is usually gum disease. 90% of the population have gum disease. Common things are common. Go and see your dentist, get them to have a look at your gums, do your cleaning, clean your teeth really well. It's actually really important to have really good oral hygiene and look after your gum health, because if you get infections or if you've got inflammation, that will drive oral ulcers and other parts of your disease. So mouth health is really important.
Okay, and mouth ulcers is a commonest cause of patients having to take time off work for all diseases, which is actually very surprising. So Dorian Haskard did a piece of work with his group. It was the commonest cause for patients not going to work. Okay, so they can actually be very distressing. And if you have things like oral Crohn's, vesicular bullous disease, erythema multiforme, BEHÇET'S, it can be, the VAS pain score out of 10 can be 10. You can't talk, you can't think, you can't do anything. Okay, so that's quite important. So is there anything else? I'm just going to, there's a question asked several times about using IL-1 inhibitors, so canakinumab and anakinra in BEHÇET'S. The problem with using that is there's not been a lot of work. There's been one review and there's been a few trials, but with very, very few patients. So the primary and secondary outcomes, I think it's not very valid. But the problem with anakinra in BEHÇET'S is patients have very reactive skins, and it causes a terrible skin reaction, and it gets worse and worse. In BEHÇET'S, in other conditions, it gets slowly better. It's not been an option. It has actually been used for familial Mediterranean fever, and in familial Mediterranean fever they use large doses of colchicine. And I think those are that. Okay. Okay, and then a whole load of questions are about the genetics, I think, and we can just answer that in one. So there's 2 things, and I'm not quite sure when people talk about genetics. There's been a huge amount of work done on the immunological effects of the genetics, so the genetics at a micro level. And we know, because we were part of the biggest group looking at the GWAS, there's a whole genome sequencing to look at, and found that HLA-B51, although it doesn't say you're going to have BEHÇET'S, if you do have it, you have more likely to have severe disease. And it also shows you that the inflammatory genes like TNF and interferon gamma lie very close to the region and peaks in patients who have BEHÇET'S, so that accounts for the patient being hyperinflammatory. But I think I know what you're all asking about. Can't we have something that's going to tell us we've got a gene, and this gene's going to be either ocular, vascular, and mucocutaneous? No. I did, however, go to the gene sequencing. You remember they did the, was it 1,001 genes a little while ago? And I've been going to the meetings in London where they have the big sequencing centres. And I almost got in there until they said, is this monogenic? And I had to say no. Well, goodbye. Okay, so I am personally very keen, but it's hugely, hugely expensive if we do that. I've tried applying for some money to do it. So if we just do single cell sequencing, which we have done to look a bit at the cellular level, 4 patients cost about £20,000. So, but if you ask any of the purists, Hiazici, anyone, BEHÇET'S itself, it's a multivariant condition. So it's your environment, it's your genes. It's if at a certain time you see a particular virus or bacteria which might act as a trigger. So all of those things come into a mosaic, all right, and then will trigger. If you underlying are hyperinflammatory, will trigger the disease. And I used to work for Tom Lehner, which some people, Desmond knew, he both put all of us were under him at some stage. But he was a huge authority on BEHÇET'S. One time he was one of 3 people in the UK. And he always believed that there was a trigger. So you might be a little bit genetically predisposed, you might live in the right environment, you might do all of those things, and suddenly something like EBV, so that's glandular fever type viruses, might trigger a disease which then becomes full-blown BEHÇET'S. And I think I wrote a paper years ago saying, can you catch BEHÇET'S? But all of them will tell you it's not only the genetics. You need all of these other things. Now, Paul Brogan's group have a really good panel. But again, what they're looking at is a particular panel of genes, and in children, because we tend to see it a bit later. You do see BEHÇET'S in children, but a bit later. And in those children, you have to make sure that they don't have one of these other inflammatory conditions, right? So, and they've been doing and trying to dissect that out. And they will also tell you it's really very expensive to do that. I think that was all. I think mainly the genetics, and somebody said one day we're going to have a test like COVID. Take a sample, you got BEHÇET. I don't think it'll ever be. It's much too complex a disease. You might catch some people and you won't find the others. I mean, I would ask, what do you think, Desmond?
Oh, I agree, absolutely. Yeah. Not everybody will have the same stimulation, and not everybody will have the same genetic background as well.
Yeah. Okay, and then, the other 2 things is, whatever we do, all us clinicians, right, the best outcomes are the effect on socioeconomic conditions of patients and the mental health of our patients. So we know in COVID, anxiety in the whole world, do you know that, had gone up like mega trillions of times, and anxiety is a huge trigger of disease, then social deprivation and things. So the 2 people who do that and who do marvelous work, actually, I can't begin to tell you, is Jean, Madam Jean, we can bend down. She bends over backwards to help with people's socioeconomic problems, and Steve, more than he should, more hours than we pay him for to try and help people with the mental health. Do you just want to talk, Jean, about what you do?
Hello. Well, I every day is different, really. So I do sort of all the non-medical support with patients. So COVID really brought a lot of new things for me to do, but I do lots of work with education, employment, benefits. During COVID, I was helping patients get food bundles, pet food for their pets because they couldn't afford to feed their pets. So I've helped with all sorts of different things. I think I work quite closely with Steve, so we often refer patients to one another. But I think it's really important to help people sort of, at the bottom with their social, economic problems, so they can then move on to other things like therapy and maybe even being more compliant with medication when somebody doesn't have housing or they can't eat. I guess sometimes the last thing they think about is taking their medication. They can't get themselves to the pharmacy or afford the bus. So help with things like that, like bus passes and blue badges. And so that's sort of every day is different.
And so, Steve, do you want to say what you do?
Well, I guess I work very closely with you, and I would say, in terms of mental health, if people can't put bread on their table and the roof over their head is threatened, then you can forget about everything else. Therapy is not going to be effective because we need to get some practical help, and that's what Jane does, and she does that really brilliantly. So it's an open referral system, as most people know. You can self-refer when you're in clinic. You can contact the clinic if you want to refer to me, and I will offer an assessment. The psychology service has moved since COVID to kind of online and telephone. We're quite concerned about initially how that was going to work, but actually I think it's worked really, really well. I feel that psychology is much more accessible for people now. Previously, I think there was a number of issues when it was mostly face-to-face in the clinics. One was you were trying to see people who came on the day to clinic and also tried to have a regular therapy service on the same day, which meant usually that at least half the people who wanted to see me on the day didn't get to see me. And I think the benefit of moving to kind of online and telephone is that you don't have to just live in London to get therapy from me. Before you had to be able to commute in to come to the clinic. Now, if my working day will be seeing someone at 9 o'clock in London, then 10 o'clock will be someone up in Newcastle, then wherever. So I think it's much more accessible for people, and I think the outcomes are the same. It doesn't really affect the relationship at all. In some ways, it's better for some people as well. Some people wouldn't come to see me if it was face-to-face. The telephone clinic has been really helpful for those people who find it very difficult to talk to someone face-to-face, and actually they could explore things through therapy on the telephone that they feel would be too inhibiting, even on the televideo. So I think it's been overall really, really successful. So a psychological assessment will be offered, and we'll have a look at to see if there is a psychological issue or if it's one of those contextual issues that we have to think about first. And we'll have a discussion about whether you get signposted to kind of local services, and if that's something you could do yourself, because most of them are self-referral, or if I need to support with that, either liaise with professionals or sometimes advise generic services about what BEHÇET'S is and how it might affect people and impact them. And therapies varies from whatever's needed for 1 or 2 sessions right through to seeing people on a regular basis for a long period of time. Most people kind of dip in and out of it, and I think that's perfectly fine. I think we really want to be flexible in how we offer services. One of the biggest I think barriers to accessing local psychological services is these kind of rules around cancelling appointments. If you miss an appointment, then they discharge you quite quickly. And of course, we need the flexibility when we're working with people with BEHÇET'S and other similar conditions. Is that they're just not going to be able to make appointments regularly because of just how the flaring ebbs and flows. So we can accommodate that. And I think that's probably all I want to say, really.
Yeah, great. And then there's one thing about, I think we're talking about PALS, okay? So PALS is a Patient Advisory Liaison Service. So we can't make everyone happy all of the time, and I really am sorry about that. But sometimes, you get so annoyed. If you're really annoyed, you can, write to us and one of us will talk to you. And sometimes you think you want to do more than that. So you use the Patient Advisory Liaison Service. And you can write to them and you can talk to them over the telephone. Okay, from the time they receive whatever you say, they will respond to you in 2 days, and then keep that as a holding. They then send it to us, and we have to send it quite high up in the trust, and then they held to account to them, and then they will come back to the PALS people and come to you. Most of the time, we can put a reasonable explanation about it, and sometimes it's about miscommunication, so it's important for us to actually bridge that gap. And, I always say to everyone, we're not God. We make mistakes. We're just like you. Sometimes it's good and sometimes it's bad. We try not to bring anything into the clinics for that, but it will happen, and you do have the authority. Now, you don't have to write in English if it's not your first language, right? There's ability on PALS to come in and either talk or write in another language. So that shouldn't be something that stops you. But I would hope, firstly, you talk to us in clinic if you're so mad that day, all right? And if something's happened, one of us would usually ring you. And if you're so mad that day, then come to us in the week. The other thing is, if you phone and no one's on the phone, look at us. It's only us, all right? And there's nobody on the phone. There's these 2 nurses. Don't put the phone down, because you'll say, I phoned and I phoned and I phoned. And you know what? You didn't answer me. Of course we didn't. You put down the phone. We didn't know where you were. All right, so leave a message, and we try. How long do we try to get back to patients? Telephone.
So within the week.
Within.
So it depends on what
comes
in, what other urgent cases.
Yeah, and we do get a whole load of people sent from elsewhere to do urgent in the week. So we're also busy all the time. And so if there's anything else from the floor, I think most of the things in the letters. Yeah.
Professor Fortune, I've got a couple here online. In early stages, the patient comes in being under an investigation for possible Graves' disease due to eye signs and thyroid levels. Can they also have BEHÇET'S, ? Or are the diagnoses mutually exclusive? Then the second bit, in my case, the patient had multiple recurrent oral ulcerations, but due to poor attendance and mental health, I am unable to get good clinical photos and records. Also, they are waiting for referral. What would you advise to a specialist care dentist in this scenario?
So this patient's got Graves' disease. They've got a hyperactive thyroid, which is secondary to antibodies. And that is quite common in young women, right? And then it goes into a euthyroid, and then you become hypothyroid. Occasionally in patients who are BEHÇET'S, usually women as they get older, we start seeing thyroid antibodies, but they don't necessarily have clinical disease. If this patient has got oral ulceration, then it should be seen by a specialist oral medicine physician, right? Because there are thousands of things that might be the cause, including the patient's medication.
I've got another one here. From a patient who obviously visited the centre. How do we make the psychological referral? Before the pandemic, saw Steve every time I was in clinic, but since clinic change, I don't know how to access the session.
Okay. Steve?
Okay, but I think we've answered that one already, actually. If you come into clinic, you just ask to be referred to me, and the clinic will contact me. They'll email and they'll contact you. Initially, usually by email, but sometimes by telephone, and we'll book an appointment and we'll arrange it that way. So that's probably the easiest way, I think, to do it. But you don't have to wait till you're in clinic. You can just email the clinic, the regular BEHÇET'S email address, and they'll then pass that on to me as well. And I'll contact you back.
Nardis, do you want to take that? What happens,
No, I think exactly what Steve said. You can just email and say that you would like to speak to Steve and have a session with him, and we just literally forward the email to him, and he will contact the patients and arrange their session with him. So we don't get involved in arranging the appointment in terms of Steve, because that's what's suitable for both Steve and the patient. We just simply let him know that the patient wants to be contacted, and he does that.
Or the patient might come to clinic, and especially if it's a new patient, we would offer them the service to be seen by Steve. And it can be equally frightening for a patient when they've been on a long journey and you've made a diagnosis. There's the relief, and then there's the shock, and then there's a grief. And then I think those, especially young people, must see Steve. So then NADOS facilitates that and sends Steve there.
And just to add to that, I mean, I know that some people avoid seeing me, which is fine, because, you know, we've talked about the medical journey, the medical merry-go-round, and people are often made to feel, have been made to feel, and have been told, and have even been sent on to mental health services because of the symptoms that they're experiencing before diagnosis. So some people I feel really quite stigmatised and don't feel concerned about coming to see me. But I just want to reassure, and hopefully my talk has reassured people as well, that, you know, that's really not the approach we take in the clinic at all. And yeah, everybody's welcome to come and speak to me, and we'll definitely have a non-pathological kind of conversation about psychological issues and mental health issues in whilst living with BEHÇET'S.
My question is about COVID-19 and other situation, the country in economic situation, NHS situation. How much did this affect about researchers like stem cell and other things? Because whenever we come to this kind of conference and things, we are hoping to hear something new or some hope.
Okay, that's why, you know, we work with the BEHÇET'S Society, and you will see there's a lot of new posters. And, oh my dear, I forgot Hannah, our PhD student who made her own poster, brought it today, and I think she's probably hiding away somewhere. So, and she's doing, you remember quite some time ago when it was our turn, I spoke about nutrition. Oh, there's Hannah. And then Hannah is doing a PhD on nutrition. And so today she's brought some data about diet, because we used to do a diet history. Actually, it didn't say anything because people just tell you what you ask them or what you want to hear. So they do a diet questionnaire online with Hannah, and we are also looking at their blood for markers in the blood of good bugs and bad bugs. We've also done the genetics of it. So a little bit of her data is out there. So we try to be responsive to the things that people say, yeah. We've identified 2 molecules for fatigue and sleep, and it's very interesting because they drive each other. And when I have money, I'll do the research with another PhD student. But all the research that we've done, a lot of that has been done with the BEHÇET'S patient support, and it's been very responsive to the things that you, the patients, have asked. So the research is there. You should have looked at the posters today. Okay. Yeah.
Professor Forge, a couple of quick ones, technical, you know straight away. From somebody, is there any concern with the use of antibiotics, specifically erythromycin with colchicine?
Well, there's a lot of the drugs that the doctors give that intact. Again, you have to be very careful. So if you get anything from your doctor, especially now, patients come to clinic to us, and I think it was Bindi or Sarah, or was it Azimun? A patient had 24 medications, right? And then you're going to medicate on top of that. It's impossible. You have to send the patient back to do a medication review. If it's something urgent, somebody like Sarah will go, or Bindi, and go and do a medication review. And that will also put the clinic out in time so that we can give the emergency drug. But every time your doctor gives you anything, right, because he's taking, he's so busy. The doctors are totally overwhelmed. He's taking old prescription. You come in with something new, and he's just adding it, isn't it? So if you're continuous and you add it, I just say to someone or the pharmacist where you go and collect the blood, the prescription, say, can you please see that there's no interaction? Actually, there's one thing I did want to inform you is we have a lot of generic drugs now. So when we first do the research, we do it on the genuine drug. Now, generic is when this drug goes out of license, then anyone can come in and make a similar drug. So they use the same active ingredient, but the excipients, like the fillers, are different. And now, where we have increasing lactose intolerance in the public, look carefully that there's not lactose in the drug. That's why the azathioprine or whatever is not working, because it's full of lactose, right? And it's just one thing to do. We finished now, and I think that's it. Is it? So thank you very much for all of you, and thank you, Tony. And I want to really thank the team after having a very, very busy week and working late last night. Everyone has turned up. And Steve has come all the way from Scotland to be here. And from America for Jean.
Thank you, Farida. I'll just very quickly finish off. We've got a couple of minutes. So, first of all, it's obviously to say thanks. And first of all, to Gemma for the amazing amount of hard work she's put in. It's taken a lot of effort. Stand up and be seen. Well done. Well done. And Martin and Ian from Aston Media have been brilliant. Thank you. This is our first time here. Much appreciated. And I'll say thanks to the Holiday Inn, who've been very responsive to some of the flexible things we've been asking for, short notice stuff like printing stuff out. And it seems minor, but it's efficient, and they could do a jobs with and say no, they don't want to, but they haven't, so that's fantastic. Jan, John and Jean, thank you for all you do. And as everyone knows here, and online as well, who's part of the Society, the input into our newsletters is vital from them, so thanks for that. Professor Fortune, obviously, and your team from London, thank you for an excellent day and for answering so many questions, so that's really good. Most online things I find, most questions don't actually get answered. For those of you online, thank you all for joining us. Please complete the feedback. If you complete the feedback, we can improve things for the future, and that'll be sent off afterwards. We'll also ensure that this recording is online so that you can look at it for those who joined. And some aspects we may even just put publicly for anybody to look at. So it depends on the permissions and all the rest of the stuff. So please use that resource, and we're going to try and do that more on the Society sort of webpage. And then finally, thank you, all of you who've made the extra effort to come here. I know it's a long way for some people, and when you're not feeling very well, it's not very good either. So well done. Thank you for your input, and I'm sure you've had a great time talking with each other, and that's what the importance of having live events is all about. And in conjunction with then getting it out into the wider world, that then helps more people. And I think that's it. Thank you. Safe home.